That's literally exactly what I was about to say to you. So I just want to go to sleep. Yesterday, I went to bed at like 9:30. 9:30? Yeah, I was like so sleepy. I was like, and I've still been getting up at like 7.
Original time. I slept at 1:20.
Yeah, I was studying and I just like slept, like I just shut down in my desk and then it was like 12 something and I was like, oh my god.
I was considering doing a hockey and I was like, I was thinking.
Yeah, but they extended.
Yeah, I got the emails.
Should I?
I'm gonna send this stuff tonight or like this afternoon.
Should I even apply?
Why not?
That's what I'm asking.
Oh, I guess I forgot. I'm first up here, right?
Did Challenge say anything about the speakers? It looks like things recorded okay last time.
They did? Okay.
So I think things are set up the same way. And then someone replaced the batteries in here.
And is it working?
Yes. It's not on right now,
Okay, that's okay.
but it is working.
Oh, that's
I think everything's working.
I miss those lapel mics so much. All right. Are we
This one's
ready?
much easier to pass.
Back and forth the baton here. Okay, great. Are we ready to go?
In 2 minutes.
2 minutes. Okay, 2-minute warning, right?
There's an experience that I used to sit in the second row in my pharmacy school.
Oh yeah.
Such a good spot, not so far that you're like completely
Exactly. I would
close
sit,
enough that you can see what's going
I
on.
would sit in the front. I felt like I didn't have to like look up at the screen. Right here, this is like direct eye level. So it's great.
My best friend sat in like the very back.
Oh yeah.
So I know that's great people.
It's also how I
So I feel like you look like her.
That's kind of you.
I can't see my heart, but it,
I want the brain. I want the brain. What it is, like lungs.
no, whatever. She didn't do pulmonary. We can get our own lungs.
Lungs and brain.
We're going.
You're going through it.
We're on the home stretch here.
Yeah.
All right.
Ready?
Start.
All right. We're right on the dot. 1:30 on the dot. All right. We got our mic back too. All right. So I feel like a roving reporter here. Okay. All right. So where we left off yesterday is talking about one of our newest classes of drugs, the SGLT2 inhibitors. We acknowledge that we were introduced to those in heart failure because they do have, there's quite a bit of good data on their usefulness in that particular disease state. But these drugs were initially developed as drugs to treat type 2 diabetes. Now, SGLT2, just if you're wondering, okay, is kind of an acronym for S stands for sodium, GL stands for glucose, and T stands for transporter, right? So sodium glucose transporter, and the 2 is just the isoform number. So there are lots of different isoforms of this protein that are produced, throughout the body. And so This happens to be one in the kidney. So the way the drugs work, as I talked about yesterday, is that they increase the renal excretion of glucose. And the way that they do that is by blocking glucose reabsorption in the proximal convoluted tubule. So if you remember, about 90% of all of the glucose that's filtered by the glomerulus and into the proximal convoluted tubule is reabsorbed here in the proximal convoluted tubule, and the SGLT2 protein is critical for that. And not only does that protein help reabsorption of glucose, but it also facilitates reabsorption of sodium at the same time, okay? So again, these drugs just block these transporters that you can see here. Tubular concentrations of glucose and sodium, increase. Now, some of that sodium will be reabsorbed in other regions of the nephron, like the loop of Henle, the distal convoluted tubule, and even the collecting duct, as you learned about in the last module. But reabsorption of glucose really doesn't happen anywhere else in any meaningful way, except for in the proximal convoluted tubule. So that glucose is then eliminated in the urine, okay? So what you're going to see here from a physiologic perspective is a lowering of blood glucose, okay? And the other components you're going to see in terms of some changes in urine. You're going to see glucose in the urine, glycosuria, which shouldn't be surprising to you based on the mechanism of the drug. Polyuria, so again, increasing the volume of urine that's produced. Again, that shouldn't be a surprise to you as well. Too, the more glucose and sodium in the tubular filtrate, you'll get water actually being secreted into the filtrate, and you'll get an increase in urine production. And then with an increase in urine production, again, there's potential for reduction in blood volume as well, too. Dehydration, lower blood pressure, those sorts of things, okay? Adverse effects here, and I think Dr. Foles is going to talk about these. Okay, so again, we can see an increase in serum creatinine and BUN. Also, hypoglycemia can happen, but it's usually in combination with other drugs. Okay, because this drug by itself, and Dr. Foles is going to talk more about it, is not one of those ones that typically can cause hypoglycemia by themselves. Again, because of all the glucose in the urine, okay, you can see things like UTIs or yeast infections, and Dr. Foles will talk about that. And then polyuria, again, increased frequency of urination, increased urine production. So I'll turn it over to you at this point. We're coming down to the home stretch, right?
Yes. All right. So I apologize. On the beginning slides, I marked which of these come generically, and I missed it on these other slides. So we actually do have one generic SGLT2. Does anyone know what it is? Dapagliflozin, Farxiga, has gone generic just this year and is available on formularies. However, it's still very expensive for the cash price, so it's still not a great option for someone with no insurance. Similar to our GLP-1 Victoza that's gone generic, or the Raglitide. It is nice that they've gone generic. Hopefully that means in the future they'll be cheaper. So it is exciting. This is the first year that we've actually had some generics in these classes. These have pretty modest A1C lowering, so not as much A1C lowering as you get with GLP-1s or even metformin. And the glucose lowering and A1C lowering potential also correlates to their renal function. So as you see here for other indications, you guys probably learned about these. Did you guys talk a little bit about SGLT2s in the last module in chronic kidney disease? Yeah, these have great data for chronic kidney disease. We have the initial data was with dapagliflozin, but it's a class effect. These are great for chronic kidney disease. However, one thing to just make note of is if someone's renal function is not good, like under 45, you think this would have a lot of effect on controlling your blood sugar. What do you guys think? No, it doesn't. So while it's still recommended for chronic kidney disease in people with diabetes and poor renal function, it doesn't have as much glucose lowering. So that's just something that's kind of a little bit surprising maybe, or maybe surprising is not the right word, but something to keep in mind. You guys also saw these in heart failure, like Dr. Coleman said. So if you see a case where a patient has heart failure or they have chronic kidney disease, you should be thinking about reaching for one of these SGLT2s as recommended therapy. A lot of times you'll have to combine it with other therapies, but they should, if they have heart failure or chronic kidney disease, be on one of the agents from this class. These are very convenient to dose. You can take them with or without food. They're all oral tablets. They're all just once a day. All right, so back to our chart. So you'll see, just like with our GLP-1s, that we've got quite a few extra benefits. We have the heart failure benefit, that I would star, and then the chronic kidney disease benefit. That's kind of unique to the SGLT2s. What other benefit do you see that's similar to the GLP-1? What other disease state benefits do you see on this chart? Yeah, they have weight loss, not as much as a GLP-1, so modest weight loss. That wasn't the one I was thinking, that's exactly right. What's another benefit that it shares with GLP-1? Cardiovascular benefits. So if someone has a history of heart attack, stroke, coronary artery disease, then either a GLP-1 or an SGLT2 or both would be a great option for that patient. All right, let's see here. So we talked about weight loss, we talked about benefits for chronic kidney disease, heart failure, ASCVD. I just gave this version of this presentation to the PAs, and I was feeling like a huge case of deja vu there for a minute. I was like, did I just talk about all this last class? But no, that was last week with the PAs. So since it does have some mild diuretic effects, it can have some similar side effects to what you saw for diuretics. So kind of thinking about things that you would see with furosemide, the hypovolemia, hypotension. That's due to the diuresis effects of these. So older people with poor renal function can be more at risk of that. And it's not unlikely for them to be on these types of agents. Let's see here. It's also recommended to stop these 3 to 4 days before any procedures. This class of drugs can cause what's called euglycemic diabetic ketoacidosis. So if you think back to slide set 1, what were some of the signs and symptoms of DKA that we had there? That was one of those like diabetes crises where you go to the hospital, get IV fluids and insulin. What were some of the signs and symptoms of DKA?
Loss of consciousness or
You could, if it got very severe, you could lose consciousness. How about for the blood sugar? Is that high or low in DKA?
it's low.
In diabetic ketoacidosis?
Oh, sorry.
It's actually normally pretty high, like 500, it could even be 1,000. However, when you have DKA that's induced from an SGLT2, glucose is actually pretty normal, but they have all the other signs and symptoms, and they have that ion gap, that acidity, the ketones, all of those things. So it's kind of an interesting phenomenon. We don't fully understand how this happens, but there's certain things that are risk factors for it. And so prior to procedures is actually one of the things they've identified as a risk factor for getting SGLT2 induced diabetic ketoacidosis. So what kind of things are people doing right before a procedure?
Fasting.
They're fasting. Yeah, so they're eating differently, they're drinking differently, and that puts them at risk for being dehydrated, and then that's what puts them at risk of this DKA. So it's recommended to avoid these 3 to 4 days before procedures to limit that risk of DKA with this class of agents. This is the only class of agents that's associated with this DKA risk. Again, it's kind of unusual, but it does happen. Like you very well might see this on your hospital rotation. That's also why it's specifically not recommended for patients with type 1 diabetes. Back when these first came out, sometimes endocrinologists would start patients with type 1 diabetes on these medicines. Because if you think about their mechanism of action, how do these work? You pee out sugar. So whether you have type 1 diabetes or type 2 diabetes, in either case, blood sugar can be high. It's just due to different reasons. So hypothetically, this could work in type 1 diabetes too, because if your blood sugar is high, you pee out sugar. So we were actually using this originally in type 1, but patients with type 1 diabetes are more at risk of DKA, and they were much more at risk of DKA when using these agents. So because of that, it's specifically not recommended in type 1 diabetes. None of the medicines we've talked about in this slide deck are recommended for type 1, but this one has a specific warning against it. All right, so other adverse effects. So since they work to pee out blood sugar, similar to diuretics when you first start these, you can see an increase in urination. Similar to diuretics like hydrochlorothiazide, things like that, if patients are on them for several weeks, normally that will stabilize, so they won't continue to notice polyuria with these. Which other class of drugs do you see like a transient spike in the serum creatinine? ACE and ARBs. This is very similar. So just like ACE and ARBs, you see that transient spike, but then overall you get renal protective effects. Same with SGLT2s. You'll see maybe an initial spike in serum creatinine, but generally they are renal protected in the long. Let's see here. There is a risk of foot amputations. This is specifically with canagliflozin, and unclear how this causes that, but they did see an associated increased risk in patients taking canagliflozin. So if patients have had an amputation, I'll generally avoid canagliflozin, but I still use other SGLT2s in those patients. And then urinary tract infections, since you're peeing out sugar, they can be somewhat common, but what's more common are yeast infections. So what I've seen in clinical practice is people that get yeast infections, you treat them, but they just continue to reoccur or be difficult to treat if they're on an SGLT2. So that's the most common reason that we end up stopping one of these. It's not everybody. Certain patients are just more at risk of yeast infections and urinary tract infections. But if you see a patient in clinic when you're on rotation, or if you are doing a case, and they say a patient has a history of frequent urinary tract infections or yeast infections, generally we'll avoid this class. Right. What questions do you guys have about SGLT2s? Yes.
Question regarding the UTIs.
Yeah.
Do you see any patient population, like older patients that
Yes. Yes, I'm glad that you said that. So the same patients that are typically at increased risk of urinary tract infections, like women versus men, older patients, it's definitely more likely in those scenarios. Yeah, great point. Because you guys have done urinary tract infections in infectious disease last year, right? Yes. Thank you. All right. I think we just have two classes. Sulfonylureas and TZDs.
Yeah, we're getting close.
Yeah, all of these are generic and cheap.
Generic cheap, absolutely. And these are old too, just like yours truly. Oh, and by the way, before I do this, speaking of getting old and getting humiliated, all right? Everybody got my email yesterday, okay? If you didn't check your email, okay, about Professor Moore's survey, okay, if you can fill that out, I would be grateful to you. Every little one counts, and I'll look forward to wearing the banana costume. So I'm sure it'll be a highlight of my 30-year academic career. Dr. Foles doesn't know what I'm talking about here, but we'll catch up later on. At any rate, we're getting close to the goal of the meeting. So, all right, so sulfonylurea drugs. So these are really interesting. These are just some of the oldest oral antidiabetic agents that we have. They've been in use since the 1950s. And they were first discovered back in the 30s and 40s by German scientists that were doing some research on sulfonamide-based antibiotics. And they recognized that some of the patients or participants in those studies were experiencing hypoglycemia and realized that potentially these compounds could be developed into insulin-secreting or blood sugar lowering agents. So because these drugs are so old, they've gone through a number of different iterations. There's first, second, and even third generation agents. I only mention the first generation agents briefly because we don't use them anymore. If we take a look here, this is the pharmacophoric structure for all the different generations of our sulfonylurea drugs. The drugs here, we have the aryl group here and this sulfonylurea group right here. And there are two substitution points, one on the para position of this aromatic ring, that's the R1 substitution, and then one over here, the R2 substitutions. And so, the differences between most of the drugs and the generations are really the different substitutions either at the R1 position or the R2 nitrogen of the urea moiety that are on the drug, okay? So, very, very briefly, the first generation agents, I'm not going to show you any structures, I'm not going to test you on them, but they were really characterized by very small functional group substitutions at the R1 and even R2 position. So we have things like methyl groups, chloride, and carboxyl groups. The second generation agents, the substitutions are very different. They're larger, they're more lipophilic and bulkier. And the effect that has over the first generation agents is that the second generations are much more potent than the first generation agents. They have a very more rapid onset of action, longer duration of action, and a shorter plasma half-life. And so all those things are kind of advantageous as compared to the first generation drugs. So if we take a look at the second two examples, and there's a bunch of these, but I just picked these two as examples. We have a glipuride and glipizide. You can see here in the yellow, I have the pharmacophoric structure of the sulfonylurea drugs, right? You see the aryl group here and the sulfonylurea group right here. The R1 substitution in this particular case is the para beta aryl carboxyamido ethyl group here, okay? And then we have a 6-member carbon ring over here at R2. And again, what that does is it imparts that better potency, shorter onset of action, those sorts of things, longer duration of action. The kinetics are much, much better with regards to these as compared to the first generation agents. Okay? Now, how do they work? So in order to understand how these drugs work, you have to understand how beta cells detect changes in blood glucose and what they do to respond to that. And we've already gone through that on day one. Remember we talked about beta cell insulin secretion, right? So the sulfonylurea agents, actually, the way that they work is that they bind to and activate the ATP-sensitive potassium channel that I talked about a couple of days ago. Now, on this slide is a step-by-step process for what happens. You don't have to really write anything down. It's all there for you. And then, again, you should at least vaguely recognize this particular picture of a pancreatic beta cell, okay? And again, the ATP-sensitive potassium channel right here is kind of the key protein in the insulin secretion process. Normally, that channel is activated when blood glucose levels start to increase, and we get an increase transport of glucose into the beta cells. Glycolysis increases, and we get an increase in ATP production, and that shuts or that turns off the ATP-sensitive potassium channel, allowing for potassium to build up in the cell, causing depolarization. So what sulfonylureas do is that they bind to a specific subunit, okay, the SUR1 subunit of the potassium channel. SUR stands for sulfonylurea. And that bypasses all of this stuff here with regards to the glucose and causes the potassium channel to close, okay? And just like increased ATP levels would. So sulfonylureas can directly stimulate insulin secretion by directly acting on and closing the ATP-sensitive potassium channel. Again, we get a depolarization that you see right here, okay? We get activation of our calcium channel, or a voltage-gated calcium channel here. Calcium flows into the cell, and the calcium will fuse with proteins and activate proteins that allow for the vesicles containing insulin and zinc and amylin and all that good stuff to fuse with the cell membrane and be released into the bloodstream, okay? So one of the things that I think is really important here is that the sulfonylureas can cause a glucose-independent secretion of insulin. So again, it doesn't matter what the blood glucose levels are, the sulfonylureas will stimulate and enhance insulin secretion. And if you have that happening when blood sugar levels are lower, that can lead to hypoglycemia. So the hypoglycemic risk here is much greater than some of the other drugs that we just talked about. That you can compare that to our incretin hormone drugs, like the GLP-1 agonists, right? Remember, those drugs, okay, cause a glucose-dependent enhancement of insulin secretion. They activate this GLP-1 receptor here, they activate adenyl cyclase and PKA and the whole 9 yards, but that all occurs in the presence of high glucose levels. So that's why you don't necessarily see a hypoglycemia with those as you do with sulfonylurea drugs, okay? So, any questions about how the sulfonylurea drugs work? They bind to the ATP-sensitive potassium channel, it causes it to close, and that causes a depolarization that eventually leads to insulin release. Any questions about that? We good? Okay, again, in case you missed any of that, there it is right there. And then, again, hypoglycemia, adverse reactions at the top, I have in bold hypoglycemia. Again, that's because the sulfonylureas can stimulate insulin release even when blood glucose levels are normal or lower. We get weight gain here. Again, there's probably two causes of the weight gain. Well, the one cause of the weight gain here is really just due to the excess insulin and its effects on the adipose tissue. I was thinking about another drug class there for a second, sorry about the confusion. Headache, dizziness, mild GI discomfort, rash, and skin reactions. So again, with any of the sulfonylurea-based drugs, you have to be careful about those hypersensitivity reactions. So, okay, Dr. Fools. Yep.
All right. So even though these are very old, you'll see that they are pretty effective. So they do have good A1C lowering, but they have quite a hypoglycemic risk and the weight gain risk. So if we look here at this chart, you guys kind of take it in here. Efficacy high, hypoglycemia risk is high. This is the first drug we've talked about so far that has a high hypoglycemic risk. It's also the first drug we've talked about that causes weight gain. It doesn't have any CV effects or benefits. It doesn't have any renal benefits. In fact, glyburide specifically has, I believe it's a prodrug with it, that has a very long half-life if people have chronic kidney disease, and so it's not recommended in folks with chronic kidney disease due to the risk of hypoglycemia with those patients in particular. And actually, all of the sulfonylureas are considered Beers list criteria. You guys learned about the Beers list? Yeah, what is that list? Potentially inappropriate in older adults due to increased risk of side effects. So it's particularly the hypoglycemic risk with this whole class, especially urine. They're not contraindicated in older adults, but if we can, we try to avoid them because older adults are more at risk of hypoglycemia. So based off of all these things, what do you think the place in therapy of sulfonylureas is? Not first line, you're right. Yeah. So in clinical practice, we typically reserve these if someone has no insurance whatsoever, because these, like Dr. Colhane said, have been on the market for many, many years. Several of them are on the Walmart $4 list, or they were. So even if you have no insurance, these are still pretty cheap. So that's one reason we're still using them. Or every once in a while, it's like a desperate effort. If you've got someone on all the things and they refuse insulin, you might potentially have them on sulfonylurea. But in general, we try to avoid this class if possible. Okay. So as far as contraindications, if you see in a case that a patient has an allergy to sulfa drugs, you would want to avoid this class. Every once in a while, this does come up. I'll see a patient that has a sulfa allergy, and I'll write a little note to myself to remember to avoid this class with those patients. And then we already talked about the renal precautions. There's also some hepatic precautions as well. Let's see here. We talked about the beers list, and we've already talked about all of the side effects. So I'm not going to reread anything. It's just consolidated here for you guys. So I'll just reiterate that probably on an exam or a case, what's the one thing that you would read in the case that might make you select a sulfonylurea? If they have absolutely no insurance whatsoever. Yeah, really that would be the only thing that I probably would have you do in clinical practice. Sometimes people are on these because they were just started on them like 20 years ago and no one ever stopped them. But generally we're not starting people on these in practice if we can prevent it. One of the things that also I wanted to touch base on with these, in addition to the weight gain and hypoglycemia, is with their mechanism, they're kind of essentially squeezing the pancreas, those beta cells, to put out more insulin. And over time, that can burn out those beta cells. And so this class can also lead to what's called beta cell burnout over time. So while they might initially work really well in someone that's newly diagnosed with diabetes, often their efficacy can kind of wane over time as the beta cells get worn out. All right, this is our last class. Here we are, coming to the last class of drugs, not the last class of PT. Got pioglitazone. I'm so fun.
They are so fun, right? These are fun drugs. They're fun for me. These are near and dear to my heart. Just ask Mrs. Dr. Colleen. That's how when we first met. She was frantically working on an article for pharmacotherapy about the thiazolidine diones, particularly triglyceride, which is no longer available.
Right.
And she couldn't find a molecular way to the drug. This is like right at the beginning of the internet, so all the resources were there. So when I left her office, I went down into the Pharmacy Information Center and looked at the molecular weight of triglyceride for her.
True love right there.
And they're right there. That was it. That was the beginning of our relationship. So, guys, if you're taking notes, or gals, fine, right? Okay. That's what happens when you're a pharmacologist. Okay, at any rate, thiazolidine diones, pioglitazone, there were a couple of these, as I mentioned before, that were originally released. This is the only one that's kind of survived.
It's hanging by a thread.
It's hanging by a thread, so maybe someday we won't even have to talk about these. But their mechanism of action is really interesting. These drugs are kind of in a broad class of drugs that are referred to as insulin sensitizers. So if you remember that one of the primary dysfunctions associated with type 2 diabetes is a loss of tissue insulin sensitivity, right? Your adipose, skeletal muscle, liver tissues actually lose their sensitivity to insulin over time. And these drugs, again, through their mechanism of action, can restore some of that sensitivity to insulin. Now, how do they do that? Well, these drugs are typically, if you take a look at pioglitazone, it's very lipophilic. It crosses biological membranes and cell membranes very easily, which lends itself to its mechanism of action because this drug acts on and activates a nuclear receptor, okay? A specific type of nuclear receptor called a PPAR, okay? PPAR is an acronym standing for peroxisome proliferator activated receptors. We always call them PPARs because it's a lot easier to say. There's multiple subtypes of these receptors. They're expressed by a lot of different tissues. And in the case of pioglitazone and this receptor, these receptors actually regulate transcription of genes that are directly involved in blood glucose regulation. Okay, and we're going to see some examples of that. If you remember again about nuclear receptors, again, here's just a cartoon picture of one. They've got a ligand binding domain, a DNA binding domain where they bind to a hormone response element. Okay, they've got activation function 1 and 2 areas where they interact with transcription factors, an N-terminal region and a hinge region where the receptor can bend into open or closed conformation. So this is kind of the receptor we're talking about. And again, they live in the nuclear space and their primary job is to regulate transcription of various genes. In the case of this receptor, it's genes that encode for proteins involved in blood glucose regulation. Okay? So we take a look at the different receptor types. The PPAR alpha is found in liver, heart, skeletal muscle, and the vascular wall. PPAR gamma is highly expressed in fat tissue or adipose tissue, brain, and the skin. And both of these subtypes regulate a wide range of genes, gene transcription and translation that are involved in glucose transport into cells, lipid metabolism, as well as improving tissue sensitivity to insulin. Okay? This is a cartoon picture. Again, just wanted to give you a sense of what these drugs work, how these drugs work. There's really nothing here that you need to, I think, focus on other than, again, this is just the general scheme. Here we have a PPAR receptor, and we can say a thiazolidine drug like pioglitazone activates the receptor. The receptor forms a heterodimer with the arytenoid X receptor, and they will translocate into the nucleus, into the nuclear space where they interact with specific DNA sequences called peroxisome proliferator response elements, and we get transcription factors that complex with the receptor dimer here, and we get regulation of gene transcription. So again, a lot of complex molecular things here that are going on. I think the thing to remember is that a drug like pioglitazone interacts with the PPAR receptors and stimulates them. Okay, this is really where the important part comes in. Okay, so what are the tissue effects of the thiazolidinediones like pioglitazone? Okay, so we're going to talk about all 3 of the major tissue types that are insulin sensitive. We'll start off with adipose tissue. Okay, so one of the effects of a drug like pioglitazone is it actually increases adipocyte differentiation, so adipose cell differentiation and growth of those cells, which can contribute to some weight gain associated with these drugs. That in turn increases fatty acid uptake into fat tissue. Okay, and again, if you remember before, high levels of fatty acid circulating in the bloodstream is implicated in the reduction in insulin sensitivity that we see in type 2 diabetes, especially from the adipose tissue. So fatty acid levels in the blood seem to be particularly important for that. Anything we can do to bring those down may restore tissue sensitivity to insulin. We also get, with pioglitazone, effect on the adipose cells are an increase in GLUT4 expression. Okay? So your adipose cells increase their GLUT4 expression, and so those cells are now able to take up a lot more glucose than they were before. That can help improve responsiveness to insulin. Okay? And then PPAR activation by pioglitazone in adipose tissue also increases the expression of specific proteins that are involved in the insulin receptor signaling pathway, like IRS1, IRS3, and PI3 kinase. And again, that actually can improve the tissue sensitivity to insulin. So that's really important. So that's the effects on adipose tissue. Okay. In skeletal muscle, we see some similar effects. We get an increase in GLUT4 expression. So now all of a sudden, skeletal muscle is much better able to take up glucose out of the blood. We also see a reduction actually in fatty acid storage in the skeletal muscle, and it's redistributed into adipose tissue. And this is referred to as the fatty acid steal hypothesis. So with the thiazolidindiones, what we tend to see is a redistribution of fatty acid storage into fat tissue and away from muscle tissue and liver tissue. And that in turn tends to improve the sensitivity of those two tissues to insulin, fatty acid steal hypothesis, okay? And then in liver tissue, again, we get a reduction in fatty acid uptake and storage, just like with skeletal muscle, that's all redistributed to adipose tissue. We also, and that in turn will increase the sensitivity that your liver tissue has to insulin. Again, this is also part of that fatty acid steal hypothesis. These drugs don't work immediately either, okay? Not like your sulfonylurea drugs or insulin or things like that that can take effect very, very quickly. And this is due to the type of receptor that they activate, okay? Remember, drugs that activate nuclear receptors, their responses tends to be delayed because you need to give time for changes in transcription to occur and protein levels in the cell to change. And that can take, up to weeks for that to occur, depending on what type of drug we're talking about. So there's a delayed effect here with these drugs that I think is important to know, okay? In terms of adverse effects, okay, edema is certainly one of them. Dr. Foles is going to talk about that, especially with patients with heart failure. We talked about that in the cardiovascular module, okay? We're not entirely sure what causes the edema, but we have two ideas about that. The first is really these drugs can cause the kidneys to increase their renal sodium retention. And again, where sodium goes, water follows. So if the kidney's holding on to more sodium, you're going to be holding on to more water, and that can lead to edema. So that's one thought about that. These drugs also are thought to maybe cause an increase in vascular permeability, which can cause water to leach out of the blood vessels, especially the capillary beds, and into the extracellular fluid, causing edema. So there's a couple of different thoughts about how that might occur. Again, weight gain, probably the major effect of that is, again, due to the edema that we just talked about. Okay? But also, another thing that can contribute to that is that adipocyte differentiation that we talked about earlier with regards to the effects of pioglitazone on the fat tissue. So that can also be a contributing factor. And then hepatotoxicity is something that, again, was experienced a lot in some of the original drugs like troglitazone, and which is why they were kind of pulled off the market. So we'll turn it over to Dr. Foles here. A lot of information for a drug that's hanging on by a thread, right?
It was really promising when these drugs first came
I remember we were
Yeah.
because they were one of the first new
Yeah.
anti-diabetic agents that had come out for ages. Before that, it was sulfonylureas and,
So they were very promising at the time, and then I think the edema, the weight gain, and then some studies that came out with cardiovascular concerns really kind of did this class in. So they were used pretty commonly, but now are not used as often. I've only had a handful of patients on these myself, actually. What is nice is they have been on. Well, there's only one agent in the class now. There used to be more, but they were taken off the market just because they're not prescribed that often. So pioglitazone is the only one left, and it is pretty inexpensive. So even a patient with no insurance, this could be a potentially affordable option for them. So that's one good thing about it. Similar to the SGLT2s, this is a once-a-day medicine you can take any time of day, orally by mouth. So it is pretty easy to take in that regard. But like Dr. Colhane said, this weight gain really limits its use, and then the concerns for heart failure. Of course, not every patient with type 2 diabetes has heart failure, but we're finding more and more this link between patients that have heart failure and those that have diabetes, and so it's not uncommon for these to be linked. And so I I would say in general, a lot of times providers want to limit the use of any medication that could potentially increase heart failure risk or complications for heart failure. So that's a pretty big deal with this one. So definitely when you think pioglitazone as a pharmacist, you should think about the association with heart failure, and it's got a box warning for that, which we'll talk about in a second. Let's see here. Yeah, so a box warning for it. It has had some case reports of causing liver dysfunction, so it is recommended to check LFTs when you start this medication. Has a box warning, contraindicated in stage 3 and 4 heart failure. But really, anyone with heart failure, this is not recommended. So even if they have heart failure, preserved ejection fraction, I still wouldn't recommend this class of medicines for them. There's also been some case reports of increased bladder cancer risk. So that's another thing that if I am thinking about starting it, I'll just double check that they don't have a history of that. It's a fairly uncommon form of cancer, but just to make sure that they don't have a risk of that. If patients already had edema for other reasons, it's also not a great option. So, for example, this one's not renally adjusted. You can use it in patients with chronic kidney disease. But did you guys talk about edema in patients with chronic kidney disease? That's very common. If people's kidneys aren't clearing that extra fluid, edema is really common in chronic kidney disease. So it's not ideal for those patients, even though it's not renally adjusted due to that side effect. They've also seen that bone mineral density, and we'll talk about osteoporosis in a couple of weeks, and this will be one of the meds that's listed in the osteoporosis slides that's been associated with decreased bone mineral density. Unclear exactly why that happens. I don't know.
They actually have been shown to inhibit osteoblasts.
Osteoblast.
Inhibition, yeah.
So has been associated with decreased bone mineral density, so that's another warning with this one as well. That's everything that I wanted to share on that. All right, so in our last couple of minutes before the break, we're going to put some of this together. This is how I would suggest studying, and I actually meant to assign this to you as homework between now and yesterday, but I didn't, so here we are. I think this is the building block that you need to know first. I might not test you specifically like, what is the generic name of Jardiance? But I could use in the answer choices all brand names, or I could use generics, or I could use a mix, and I would expect that you would know what that is. So I want you to take a minute here with yourself or a partner and see if you can list some of the agents in these classes. And don't look. Because I know that you can if you look back at the slides.
Excuse me, thank you.
But I don't get it. Or not.
Yeah.
Or you should now.
Thank you.
I thought you wanted All right. So our GLP-1s, what do those all end in? Tide. And then what are some of the brand names of those? Ozempic, which is injectable or oral? What's the oral of Rybelsus? Alright, what's the only generic GLP-1? Liraglutide or Victoza. Also extended but we don't really talk about it. Alright, what are our two once a week GLP-1s? Trulicity, which is generic what? Ulaglutide. And then, what's our other once a week GLP-1s? Ozempic, semaglutide. Perfect, okay. You guys got those. The extended times, I think will soon be off the market. The extended release RDs. Sulfonylureas, they all start with what letter?
G.
G. What are the three what? Glycoside, glyburide. Which is the one that has such a long half-life in chronic kidney disease? It is glyburide. The one with the B is very bad. So there's no reason to ever prescribe glyburide, in my mind. So really the only sulfonylurea I see used very often is glipizide. Alright, then our TTDs, there's only one. Actosisogramine, which generic is hydrolizone. Alright, our one big Y, metformin. It's been generic for a long time. Sometimes I'll still hear people say glucophage, which is a fun name, right? It makes it sound like this big phage out there eating glucose. How about our DPP-4 inhibitors? Januvia is one of them. Januvia, which is sitagliptin. There's another one. What's the one that's just one dose no matter what your renal function is? It's 5 milligrams. Januvia is 100.
Sounds really down.
It does. Yeah. You know, it's L-linagliptin. Linagliptin, which is trifenta. It's not used super often, but I could see that be something that's on the map, like if you ever see the 5 milligrams, that's the only dose it comes in. Alright, there's also saxagliptin, allogliptin. Alright, and then what are all of our SGLT2s ended? Flozin. Yep. So what are probably the two most common flozins? DAPA and then empagliflozin. And so you guys saw those all the time in heart failure and also chronic kidney disease. There are some other ones, but those are the two that I mainly see in practice that are on most formularies. Awesome. Which one's the one that's actually generic? Farxiga, dapagliflozin. Awesome. All right. I'm not gonna go through this chart, but what I recommend is when you're studying, put yourself on the trends of these things. So I would look at it and be like, okay, efficacy-wise, which of these is the most effective? Which class?
No.
GLP-1s. Yeah, and specifically, which GLP-1? Yeah, tirzepatide, the GLP-1 GIP is the very most effective. Then I would look at hypoglycemia. What's the only class we talk about with hypoglycemia? Sulfonylureas, that's really the only one. You'll see on some of our slides we list hypoglycemia for other classes, but generally that's if you use them in combination with other agents. And just kind of like hypertension agents, yes, they all cause hypotension. Yes, all of the type 2 diabetes medicines cause hypoglycemia, but really the main one that does are the sulfonylureas. Which ones improve ASCVD rates? SGLT2s. And what other class? GLP-1s. Yep. Which ones specifically help in heart failure? SGLT2. Which ones have the best data for chronic kidney disease? SGLT2 again. Yep. So look for kind of trends. Most of the side effects and benefits are all class effects. All right. So definitely quiz yourself on these, don't just look at the chart. We've gone through this, but I want to, just a couple of minutes. So also kind of fill in this chart yourself. So I'm gonna give you just a minute to guess and kind of break down what classes you think would go in this chart. We kind of answered it by just looking at the previous chart. So let me orient you maybe to this first. So the first blue box there is ASCVD risk or high risk for ASCVD.
So that's
So then, yeah, put what classes of drugs you think would be recommended for that patient. I apologize, I should have kind of oriented you to this. So this chart is kind of strategizing which classes based off of what characteristics. So the left side of the chart under the green banner are looking at different disease states that a patient might have and then what class of drugs might help them. So this first one, ASCVD, you guys just told me what classes would help those patients. SGLT2 and GLP-1. Excellent. If their A1C was pretty elevated, I'd probably start with the GLP-1 because I know they have more A1C lowering. Or if they had like chronic kidney disease or heart failure as well, then maybe I would lean towards those first. So it kind of depends, but you could use either one. If blood sugar is still not at goal, you can add the other. All right, how about heart failure? SGLT2, yep. How about chronic kidney disease? SGLT2. I know it's a lot of repetition, but I want you to be able to wake up in the morning and know SGLT2 is for patients with heart failure and chronic kidney disease. All right. For glycemic management, which ones have the very most efficacy? One thing I want to point out, actually, going back to the left side. So if they have ASCVD, heart failure, or chronic kidney disease, those classes are recommended no matter what their A1C is. So even if the patient, let's say they have an A1C of, let's say 6.8, but they have heart failure, they're on metformin, regardless of the fact that their A1C is 6.8 on metformin. Since they have heart failure, they're still indicated for an SGLT2. The same would be the case if that same patient, instead of heart failure, if they had chronic kidney disease. Now the right side is other considerations to try to get their blood sugar to goal. So if we want to look at glycemic efficacy, you guys just told me which agent has the most glucose lowering potential. Tirzepatide. And then what's the class, which is our GLP-1 GIP? And then what other class has pretty good glucose lowering potential? Yeah, metformin has pretty good. Metformin, sulfonylureas, pioglitazone, all like somewhat similar. But the GLP-1, GIP, and then the GLP-1s are the most effective. And then we talked about DPP-4 as being kind of some of the least effective. All right, as far as weight loss or minimizing weight gain, what's going to be our best option if our number one priority? Mounjaro, our GLP-1 GIP. What's right under Mounjaro? The other GLP-1s. So Ozempic or semaglutide. Excellent. What's right under those? Something that still causes weight loss, but not quite as much. SGLT2s. Yep. They have some modest weight loss. What are some things that are weight neutral under that? Metformin. There's another class that's neutral. DPP-4s. And then what are our two classes that actually cause weight gain?
just on your views.
Yeah, so monourea and thyroid. So this chart really takes, if you knew all of the things in this chart, this just puts it in an algorithm if you're applying it to a patient. So if you know the information on the one chart, you know the information on the other chart. So I printed these out. I recommend reviewing them, quizzing yourself on them. Really, it's a nice consolidated information. Alright, so moving on. Alright, so metformin for almost all patients with type 2 diabetes, unless there's like 2 reasons you wouldn't use it. Unless you think about it for a second. 2 reasons you wouldn't be able to use it.
There's serum creatinine,
Serum creatinine under 30. Excellent. And there's one other reason. It is tougher.
Is the there's like intolerance for
Intolerance, yeah. Yep, so either a serum creatinine under 30, or they just simply can't tolerate it. You did all the things you could. What were the things we recommended to help make metformin more tolerable? There's lots of things you can do. Start low, go slow, take with food, formulation, use extended release. I think that's everything. Yeah. Sometimes you do all those things and people still can't tolerate it, so that would be one reason not to use it. And then the cutoff renal function, if you see in any case, always look at their estimated GFR. If it's under 30, you can't start it. All right, the next thing to look at if you're looking at a case is, do they have ASCVD, do they have heart failure, do they have chronic kidney disease, and then you would apply the algorithm we just looked at. So regardless of what their A1C is, if they have any of those conditions, then they're directly indicated for either GLP-1 or SGLT2, it depends on which of the disease states they have. If their A1C is more than 1.5% above goal, it's recommended to consider starting 2 things right off the bat, or starting a GLP-1 that has the potential to lower by 1.5 or more. So that's another thing. Sometimes we'll start 2 things. Very similar to what you guys learned in hypertension, right? If they have stage 2 hypertension, you should probably be starting 2 medicines right off the bat. The studies show that if you start just one, it takes a really long time to get them at goal, or they never get to goal. And then our next slide set that we're going to start after the break is when to consider injectable therapy. So we've talked about non-insulins, but it's very common to use insulin in patients with type 2 diabetes. And these are 3 kind of indications that you might need to consider insulin. That's if their A1C is over 10, or just a random blood sugar is over 300, or they're just really symptomatic. So what were those 3 P's we talked about in the first slide set? Polyuria, polydipsia, polyphagia. If you see that in the case, that means the patient's very symptomatic, they're very insulin deficient, and they probably need to go ahead and start insulin. You might be able to transition them off insulin and onto a GLP-1 or onto metformin, but generally those patients will start metformin and insulin right off the bat if they have any of those characteristics. All right, let's see here. 2 therapy. We'll continue to escalate therapy until we get their A1C to goal. Generally, if they're on 4 non-insulin agents, adding a 5th is not going to get them to goal, and you'll have to add insulin therapy. So that's what we'll talk about next. All right, so we'll start out, we'll go through this case, and then I have a couple of practices, and then we'll go to insulin. Yes? Yeah, so the question, if they're not at goal, do you raise the dose or add another agent? Yeah, generally we'll max, it kind of depends, but we'll max out the dose if they're not that far from goal. So SGLT2s, most of them come in 2 different doses, like Jardiance and Empagliflozin, so you can increase the dose. Metformin, you guys know you have to start low and increase the dose. All the GLP-1s, you can increase the dose. So a lot of times we will max out the dose of those before adding another one. It's a little similar to hypertension in that case, except for you might need to start multiple agents right off the bat and be titrating both of them potentially. All right, so if you guys want to go ahead on break, we'll restart at 2:40, and we'll start out with this case.
Is there any change?
I think it might change. I know I have them today, right? I just put them on myself. Yeah.
Miss Cindy, she's back.
Yeah. I'm not feeling sure how to eat
Okay, so how are we gonna divide this? That's what I was really. Oh, you have them down there?
Yeah.
Perfect.
Okay.
I didn't scroll down.
She's okay. This is
That's a lot of slides for the long hair.
yeah.
25 slides.
So this is a medical history. She has type 2 diabetes and hyperlipidemia and cancer and hypertension.
Okay.
So she is on the metformin. Okay. And my case, it's you got it.
Oh, that's not her meds.
Yeah,
sorry.
Yeah, let's see. This is her meds.
Oh, she's not on very many things, is she?
Yeah.
Is that the dose of metformin she's on? Just
Yeah.
500 once a day?
She tried to take 2,000. She has like medication or something, so the doctor told her to just take 1,000.
Wow.
Yeah.
Is that
So-
extended release? Or
She did.
yeah.
And actually, I looked at like there's like table of her medications from the doctor. It didn't say anything about IR.
If it doesn't say, if a medicine doesn't say if it's IR or DR, what is it? DR? No. So if it doesn't say, then you just assume that it's IR. Yeah. So just medications are normally IR unless they say they're DR. That makes sense.
Yeah. Okay.
Anyways, I know none of these things were actually your question. What was your question?
So I want to know if she needs. I don't know what's her A1C,
Okay.
but my article is about like. So my article is about like comparing the metformin with GLP or the non like metformin any oral like hypoglycemic medications or insulin. So the metformin with GLP-1 was like better for them. The hypoglycemic was so my question is, should I like add Ozempic for my plan? Should I add Ozempic or just the metformin?
I guess it depends on multiple factors, right?
Yeah, exactly.
So I guess my first question would be, does she have anything in her past medical history that would support use of the GLP-1?
I was
Oh, I gave it up.
I don't think so.
Because what would we want to see in her past medical history that would support use?
The EC.
Yeah, ASCD. So does she have clinical ASCD? Yeah, hypertension is a risk factor for ASCD, but it's not.
That's not. And I don't know her. If her A1C was high, maybe like you said, higher than 1.5.
That would be helpful to know.
But yeah, so I just wanted to ask you about your opinion. So,
Yeah. What was your trial that you looked at?
it was this one.
License outcomes of individualized treatment approach for older vulnerable populations.
Yeah, it was good.
So it looks like it's looking more at what the glycemic goals should
Yeah.
be. Is that right?
Yeah.
Okay. So it
I
wouldn't
don't have
necessarily.
A1C, like or any like the group like there was nothing with the blood groups that
Gotcha.
makes it harder to decide which medication should I add.
Yeah. At the very least, she should probably be switched to extended release metformin if she's only going to take it once a day. And then I would recommend the American Diabetes Association have a whole chapter on treating diabetes in older adults specifically. That I think would be really helpful for your case presentation. So if you want to, I can kind of show you what it looks like. Have you pulled up the ADA guidelines before?
Yeah. I already have like references now. I already have like references from the improving care that 2025 thing.
Okay. So let's go to your browser and type in just ADA diabetes guidelines. I would probably use this for like the background of your case, because one of the things on the rubric for long-term is like what are the key recommendations from the guidelines.
Yeah.
Alright, and then that. I have a whole chapter for all of it. So let's scroll
Yeah, this
down.
one that I not did this one actually. This one.
Well, this is all the standard of care. These are just different chapters. So there's one specifically for so there it is. Yeah, so I would take a look through that. Because they have a nice algorithm and everything too.
That's what I'm
And I would use this for like your background, and then you can pull it back in your assessment and pull it into. Here's your long care. Do you have to get like your questions approved for the first part?
Yeah, I already said no. That's why I was like, she said they had like you have to do it
Yeah,
So I
and
think
then like
the clinical trial and like both together it's gonna like lower the high base, not lower the high base. It's like good for like lower the A1C and at the same time it doesn't cause hypoglycemia.
gotcha.
Yeah, I don't know if she needs it.
Yeah. So that might be what you put in your assessment, is something like maybe if you don't know what her A1C goal is. I would put in your assessment what you think her A1C goal should be.
Yeah,
And
she
then-
asked me that as well. What is the goal for her?
Exactly, yeah. So I think having
Am
a
I gonna feel for investigation?
it probably will talk about it in here, and then we talked about it with that one chart with those factors too.
I think if it's like this, then population or just like
7% is the in general.
okay.
And then we had that one chart that said if they had like lots of other conditions, limited life expectancy, low motivation, that maybe you would consider a higher level.
Yeah.
So take a look at that and then try to decide if we should give her patient specific goals. This will probably talk a little bit about it.
Yeah.
As well. So I was gonna do this because it's not super long, I don't think. And I think it might give you
Yeah.
a good.
Yeah. Okay. That's
Oh, yeah, this one does talk about ambulance, yeah.
Okay.
And I would cite this chapter.
Yeah, exactly. Yeah.
Here we go.
Real quick before
Yes.
we get started. Remember, we're going to go into slide. Summarize.
That was cute.
Remember, we got those pictures.
Does it have like
Okay. I don't need to discuss anything, other than that.
Okay,
Sound good?
that sounds good. Thank you.
Yep.
All right, so here we go. This case. We have a 40-year-old comes to clinic for a diabetes visit. They've just been diagnosed with diabetes, so they're not on anything yet. First off, based off this, what do you think their A1C goal is?
Well, she's not diagnosed.
Oh, she is diagnosed. Yep.
So,
So she's here for a diabetes follow-up. We can say she was diagnosed in the last visit and she was referred to you to start some care. Less than 7. Now, if the case said that she was 91 and limited life expectancy, she had lots of other health conditions, she wasn't motivated, then maybe you would shoot for less than 8, less than 8.5. But there's nothing in this case that suggests that it would be anything but less than 7. Okay? All right. She says cost is a major issue and she has no insurance at this time. Hopefully we'll set her up with social work and they'll sign her up for some insurance, but at this time she doesn't have any. What medications could we potentially give her? She has type 2 diabetes, hypertension, depression, she's on lisinopril, fluoxetine. Her A1C is 8.8. Her serum creatinine is 1.1. Her BMI is 30. If she has no insurance, I'll let you, don't shout it out yet. I know you kind of think about it for a couple of seconds. There's really 3 options that could be affordable for someone with no insurance. So, how do you think about it? If it's not up there, don't. If something's not up here, don't make it up.
You say that the vessel needs something, right?
Yes.
we assume that the DFR is.
It's creatinine clearance. Yeah, I should have just given you an estimated here, but creatinine clearance.
Oh, yeah, it's good. Okay.
Maybe metformin.
Yeah, so metformin could be a great option. We talked about it is first line. It's very inexpensive. Their A1C is 8.8, so how far above that goal is that? 1.8. So it might not be enough all by itself, but metformin would be a great option. What dose would you start? 500, what type, formulation? ER. What are you gonna counsel her on?
Liquid food.
That. Stomach upset is pretty common with this, diarrhea is common with this. We'll start you on the ER formulation to minimize it. We'll start you at a low dose, take it with food. So since we expect that it won't necessarily get her to go all by itself, what are our 2 other classes that are inexpensive? So diarrheas and what's the other one? Pyolism. Why are those not ideal for her? They can both cause weight gain. Her BMI says is 30, so she probably doesn't want weight gain. So if we could avoid those, that would be ideal. So what non-medicine might we encourage her to try? Exercise.
Diet.
And diet. Yep. So how many minutes of exercise are recommended for everybody? 150 minutes a week, which ends up being 30 minutes 5 days a week if you want to spread it out like that. Excellent. The DASH diet, the Mediterranean diet have benefits. I was specifically the Mediterranean diet, which you guys probably talked about in hypertension. Yeah, so those things could help. So maybe that's part of your plan is like, we'll start the medication and maybe there's some room for some lifestyle changes to help with getting the rest of the way. Okay. Let's see here. So let's say she met with social work. Now she has Messenger Family Choice. So it's the same patient, but now she has insurance. I'm gonna let you think about now what might we consider for her. Is that highlighting working for you to what is it? So let's see, did it say any? It says she has hypertension and depression. That's a great question, so we definitely need to know that.
You can't recommend GLP-1 because she have a history of thyroid cancer. But she have heart failure, maybe CGLT. Well, CGLT2.
Yeah, so I think a GLP-1 would be a great option. It could help with some weight loss. Since your BMI is 30, you could do metformin and a GLP-1 at this point. Or what's another class you could do? You could do SGLT2. Metformin plus an SGLT2 would probably be enough to get her blood sugar to fall. So either one of those would be appropriate.
She have history of cancer.
Of thyroid cancer?
Thyroid cancer, yeah, that's
Did I
why I
just-
say that maybe.
Oh, okay. We haven't gotten to that point yet. Oh, there's no thyroid cancer yet.
Okay.
I'm like, where is that? Yeah, so either an SGLT2 or a GLP-1 based on the information you have so far. Yeah. Okay, so these are just some hypothetical scenarios then. So let's say in the past medical history for this same patient, it actually has that she has had a heart attack. Now, what would we recommend first line for her? SGLT2 or GLP-1. They both have ASCVD benefit. So it actually doesn't change our recommendation, does it? However, we recommend these regardless of A1C. So for example, maybe we started her on the metformin, she did lifestyle things, she got her A1C under 7. If she had a history of ASCVD, a history of a heart attack, stroke, then we would want to try to get her on an SGLT2 or GLP-1 to prevent future events. All right, so either of those. All right, now let's consider some other patient-specific factors. So let's say she tells us, I'm definitely scared of needles, no amount of counseling in the world will make me feel comfortable with this. What options would be options for her and what things should we avoid? Yeah, she could do Rybelsus if she wanted a GLP-1. What other options does she have? She can still use metformin. She can use an SGLT2, all of those are oral. Yeah. So basically, she just wants to avoid any injectable GLP-1s. Ooh. If she had frequent yeast infections and UTIs, we'll avoid what? NSAIDs. The SGLT2s. My timing is off here on these. How about she tells you, I want to be on as few tablets as possible. What might be a good option for her? GLP-1, but which specific GLP-1s might be really good? Well, she's saying that she wants to get as few tablets as possible. Like she doesn't want to take so many tablets. These are different scenarios. They're not all inclusive.
Oh, but, okay,
These are all separate.
Okay, she doesn't have
It's not,
fully the
I
needle
know it's a little
centimeter.
confusing, this is
Okay,
not
okay.
compounding, these are just separate scenarios. Yeah, why isn't it?
It's one something.
It's once a week, and it's not an oral trial. Yeah, so this is separate, this is she's, instead of the needles, now she's telling you, oh, I want to, this is a different kind of scenario in there. I apologize, I know that's kind of confusing there. So she's telling you, I want to take as few tablets as possible, so Ozempic, taking that once a week. Number one, it's an injection, and it only has to be taken once a week. Alright. Let's say that she has a history of these things. Heart failure. Now what do we want to recommend for her? SGLT2? Ideally an SGLT2, because they're guideline directed therapy for heart failure. What medicine will we not use if she has heart failure? Pioglitazone or actives. Yep. Alright. Sitagliptin and saxagliptin, well, ideally avoid those two. They've been associated with increased hospitalizations for heart failure. But the main one I want you to know about is pioglitazone. Alright? How about the thyroid cancer now? I know we are excited about the thyroid cancer. So I guess if we want to think about this, what are we gonna avoid? Yep. What could they take? They could take an SGLT2. What's similar to GLP-1s that would be okay? They can't pick a GLP-1, but they can take something similar. No, they can't do the GLP-GIP. What's similar to the GLP-1s? It's considered a drug interaction if they're on both of these classes.
Oh, the
DPP-4s. Yeah, this might be a good time to use a DPP-4 since you can't use the GLP-1s. Alright, so how about if she had a history of pancreatitis, what classes would we avoid?
The
DPP-4s and GLP-1s. So that's a side effect they share. Alright, but what could we use if they had a history of pancreatitis? We could use SGLT2s. We could use metformin. Yep. Alright. So this is kind of how I would quiz yourself, and these are the things to look for in the case. Alright. So I will post these that have answers to other cases. So you guys don't have the answers to these, but I will post them for you so that you can try to fill them out first without seeing the answers. When you're studying for this, double check that you can meet the objectives. Do a lot of active recall with the charts that I gave you. I forgot to bring them. So if you didn't get a chart from me and you want one, I will bring them tomorrow. Make sure that you know that you go through that thought process and be looking on the lookout in cases. Is there reasons why I need to avoid a certain class, or is there a reason why a certain class might be indicated? That would be the thought process. And then I've got quite a few different pieces. There's a practice piece that's posted. That doesn't count against your grade. I think everyone should do the practice piece. That will really help set you up for success for Thursday's exam soft case. There's also a bunch of practice quizzes too. All right, so moving on to insulin, which is very exciting. Dr. Colhane and I think it's all very exciting. We're really thrilled to be with you. I don't know if we mentioned that lately. Okay. All right, I think Dr. Colhane.
Absolutely, yeah, let's do this. So I've got some good news for you, okay? The insulin stuff is typically very mid-chem heavy. In the past, I've done a lot of, we've learned a lot about the amino acid structure of insulin, some of the changes that we could due to that molecule to change its pharmacokinetics. Dr. Foles and I talked, and we felt that it might be better to simplify it a little bit. So as compared to previous years, there's a lot less med chem here. Okay, we might lose a little bit of context, but if you have questions, don't hesitate to ask. Okay, so we're talking about our insulin analogs here. So historically speaking, for many, many, many decades, up until the 80s and 90s, the insulins that were used to treat type 1 and type 2 diabetics came actually from animal sources, pig and cow pancreases. And then in the 80s and early 90s, with the help of recombinant DNA technology, we were able to start making synthesized versions of insulin. And what that allowed us to do is to actually modify the amino acid sequence of the insulin molecule to customize it, to get it to have the pharmacokinetic properties that we were looking for. Prior to that, we could change the pharmacokinetic properties of pig and cow insulin, but it would require additives to the formulation like zinc and protamine and some other things. And again, was it helpful? Sure, but it certainly wasn't as effective as the genetic modifications that we have been able to make to insulin since then. So to start off, one of the things I want to tell you is that all of the insulins that we're going to talk about in this lecture all have the effects that regular insulin does. Okay, so all the stuff up here in terms of the effects on liver, adipose, skeletal muscle tissue, all of our genetically engineered insulins that we're going to talk about have these effects. The major difference between those insulins is their pharmacokinetic properties. Got it? Okay, and that's what you're going to need to know. All right? All right. So there's a lot of different strategies that we have used and currently do use to help us to develop different types of insulin with different onsets of action and peak effects and duration of action. And in a lot of cases, we can use different combinations of those insulins to try to, as closely as possible, mimic normal pancreatic secretory patterns of insulin. That's really kind of the goal with this. Now, with insulin pump technology, that we've gotten a lot better at that, and we have to rely less heavily, especially for type 1 diabetics, on as long as they have access to a pump, with combinations of different insulins that have different pharmacokinetic properties. But let's go through this particular table here because it's kind of summarized. All right. So in the first column here, we have major approaches that we've used in the past and currently use to help develop insulin molecules or insulin formulations with different pharmacokinetics. Okay. So one of the first ones that we'll talk about is changing the amino acid sequence of normal human insulin. Okay. Now, if you go back to day one, and this is going to be a little foggy, all right? But if we go back to day one, remember we were talking about insulin packaging and secretory vesicles. Remember I talked about the suitcase analogy, right? And how insulin can complex around zinc cations and form those hexameric crystals. There's one amino acid in the B chain of insulin, okay, that is critical for the formation of those complexes around zinc, and that is the proline at position 28 on the B chain. So what we realized is if we can change that proline to another amino acid residue, the insulin molecule will lose its ability to form those hexameric complexes, and when you inject it, it will rapidly absorb into the bloodstream. Okay? Because remember, if you inject insulin and it's in a hexameric complex around zinc, it takes a while for that hexameric complex to break down into monomers, dimers, and then monomers, and then be absorbed into the bloodstream. So this first one here is really essentially in all three of these types of insulins, listro, aspartate, glycine. What we've done is we've modified the insulin molecule, eliminated the proline at position 28 of the B chain, and replaced it with another amino acid. Okay? And what that does is it stops the insulins from clumping together, okay, and forming those hexameric complexes, which means the insulins are in their monomeric form, their individual molecule form. They get absorbed very, very quickly. Okay? So again, the general effect on the pharmacokinetics, or the action of these types of insulin, they work much faster, and they have a shorter duration of action. Okay, again, we're going to get into more specifics in terms of the pharmacokinetics as we go through each individual insulin, but this is kind of a general summary. Okay? Why these types of insulins are useful? They're used to cover mealtime glucose. So again, these are types of insulins that you might administer prior to a meal in order to cover that postprandial spike in blood glucose levels. Okay. Another strategy, and this is actually one of the newest strategies, is that we can take a human insulin molecule. Again, there's some amino acid modifications that occur, and we can add a fatty acid chain to it. Okay? Remember we talked about this strategy with one of the oral drugs to treat type 2 diabetes. And what that does, like Detamir or Degludec, is allows those insulin molecules to bind to plasma albumin. Okay? And what that does, it gives us a slow, steady release of insulin over a long period of time. Okay? And that really can be useful if we're trying to mimic the basal level of secretion of insulin that the pancreas does throughout the day. Okay? Your pancreas, again, 24 hours a day is secreting and releasing insulin at a very low level. And then when you eat, insulin levels spike, right? We saw that in kind of the insulin secretory pattern, at the basal level. And these types of drugs, like Detamir and Degludec, can mimic that basal insulin secretion really nice, whereas these ones up here can mimic that spiking insulin that we see following meals or following eating. Insulin glargine is really insulin. It's really insulin. It is really insulin, but it's really interesting. Again, it is very similar to human insulin. There's 1 or 2 amino acid changes in that molecule. And what that does, those amino acid changes in this case, makes insulin glargine very soluble in an acidic type of solution. So the way that insulin glargine is formulated is it's dissolved in a mildly acidic solution. And that's what you inject into the subcutaneous tissue of a patient. And then what happens is, when that molecule hits the subcutaneous fluid, right, which is more basic, the insulin starts to crystallize and precipitates out of solution. And those insulin crystals are then absorbed very slowly over time, okay? And so again, it's a very slow kind of effect in absorption. There's no real peak in the insulin effect. It's kind of, again, it mimics basal insulin really well. We're going to show you some pharmacokinetic curves here in a little bit and can provide 24-hour coverage. So that's a really unique strategy that we use to help to create this, this basal insulin that we'll talk about. And then our, kind of our oldest trick or strategy, we can mix human insulin with protamine or zinc, okay? And an example of an insulin that utilizes this strategy is NPH, and Dr. Foles will talk about that, right? Again, the protamine and zinc really promotes the formation of large insulin molecule aggregates. So lots of insulin molecules start to stick together after the insulin's injected. And again, they have to, those large globs of insulin that are stuck together, boy, that's a great scientific term, right? Slowly break down over time and are released fairly slowly. And so again, you've got an intermediate type of action here, okay? And again, it can be used to mimic basal insulin, but it's, again, injected multiple times a day. And Dr. Foles is going to talk all about that. So again, we've got at least 4 different strategies here that have been used historically to take human insulin and modify it so it has a unique pharmacokinetic, properties. Okay, and so some of our insulins are very rapid acting, they take effect immediately and then they disappear very quickly. Other insulins, again, you've got a slow onset of action, it covers a long period of time, and then we start basal insulin, and then you have insulins in between that. Okay? Does everybody understand, get that kind of basic principle? Okay? You know, again, without going into detail, I mean, if you're interested in some of the details here, please come and see me. I can show you some of that stuff if that's something that you kind of really enjoy. All right? Now, again, and this is kind of the bridge point between Dr. Foles and I, right? When you're taking a look at these different insulins with different pharmacokinetic properties, right? And you're selecting an insulin to use, and there are 3 different parameters that are important to really consider, right? So onset of activity, all right, this is the time it takes for insulin to start working, okay? So again, these types of insulins, again, after they're injected into the subcutaneous tissue, they're absorbed very quickly and they start to work very quickly, okay? Again, we have longer acting insulins with slower onsets of action, and these are insulins that take time to be absorbed, and then they have other things, about them that again, extend the duration of their activity, okay? Peak effect is the time period in which the insulin is working, most effectively. So we're gonna show you kind of curves that show you when insulin levels peak with each of these different insulins. Some of the insulins, because of their kinetics, are peakless. They go up and then they stay level at a certain level and then they come down again. All right, so some insulins have a peak to them, in terms of their effect and their levels. Other insulins are peakless. All right, you'll be able to see that in the curve. The curves we're going to show you pretty quickly. And then again, duration of activity. Okay, in general, okay, when we think about our insulins, we've got short acting, and again, this is a generalization, it's a little bit more specific than this, but we have insulins that are fairly short acting that, again, start working immediately. They cover post-meal elevations in blood glucose, and then they disappear very quickly. We've got insulins that have more of an intermediate effect, and then we have long-acting insulins that can mimic the basal insulin that your pancreas puts out throughout the day. So again, Dr. Foles is going to talk all about how to choose those and how to use them together in combination with one another in order to treat patients with type 2 diabetes, right? Because Dr. Foles says it's, sometimes in patients the disease progresses to a point where you need to initiate insulin therapy. This is also extremely important for type 1 diabetes, all right? Because remember, in type 1 diabetes, the pancreas is not making insulin at all. So all the insulin the body needs has to be administered exogenously. Otherwise, your body can't utilize glucose and amino acids and fats and things like that. Okay? I don't know if this is yours or mine. Do you have anything to really say about that? I can't remember which one.
Yeah, I think we both used it. We just are trying to mimic this with exogenous insulin.
Yeah, and again, I think it just reinforces some of the stuff I was talking about before. You can see here, right? When you take a look, and this is kind of a graph that shows normal body, normal pancreatic insulin secretion, right? And so you can see here at breakfast, we get a spike in insulin production, right? That is very transient, it goes back down again, and we have another spike in insulin release after you eat lunch, right? And then at supper or dinner time, again, you get a third spike. But throughout the day, your body is making basal insulin too, all right? So this covers blood sugar in between meals, okay? And again, I think the breakdown, if I remember correctly, about 50-50, so again, the total amount of insulin that your body produces, and I think when we're dosing insulin, we take this into consideration. About half of it is basal insulin, the other half of it is insulin that's produced right after you eat in those spikes, okay? Everybody got that? So we're really trying to mimic these secretory patterns, and it's tricky, okay? To do that with just with insulin. Yep. There's 50% prandial goals, 50% basal. So again, that's kind of the goal in certain patients. We're looking for a 50-50 split between the amount of those two types of insulin. Okay. Is there anything here that you wanted to cover?
I feel like this slide's kind of the same as the.
Yeah, I do too. Yeah, so we could probably just.
So we're gonna talk about basal insulins first. So they would be the insulin that's kind of covering just this bottom part. They're not covering for meals, they're just trying to replicate the insulin that your body makes at baseline. So think basal, think baseline. There's 3 different types of insulin in this area. I don't know if you guys have the learnings for Care Lab, but I know that was last year, right? In fact, I was just in Care Lab and we'll be again tomorrow. I do a lot of diabetes right now. Care Lab, it's a fun time. So intermediate, long-acting, and ultra-long-acting are all considered different types of basal insulin. So this is a nice chart that consolidates all of them. So insulin NPH is considered intermediate, but it is a basal insulin. It was kind of one of our original insulins that we used back in the day. I would say most often we're not using this anymore, and we'll talk more about why in a second, but it's still on the market, so I'll still talk about it a little bit. It's typically dosed twice a day, and again, we'll talk more about it in a second. Brand names, okay.
What type of insulin is it used like in the hospital setting? Is it NPH or?
In the hospital setting, it's almost always glargine that's on formulary. Yeah, so it's kind of confusing. So when I say pharmacy formulary, I normally mean like each patient's individual or insurance formulary. But then hospitals also have their own thing that's called a formulary too. And so it would be different insulins might be on different formularies at different hospitals, but some form of glargine would probably be what's on most formularies. Any of you guys working in hospitals that have seen it? Yeah, it's glargine. Do you know if glargine's on your formulary?
It's everything.
Oh, you have all of it? Oh, okay. And she's all of it. Georgia, what, was that what you were going to say? Or?
Yeah, during the rotation, it's glargine.
Yeah, glargine's what I've seen most often on hospital formularies. That's it, yeah. So NPH used to be something, sometimes they would use them in VAs on formulary, but even VAs now, glargine is what's available. So I do think important for you to know that Humulin N, Novolin N, the N stands for, what do you think? It doesn't stand for normal, it does make sense, but it's not normal. What type of insulin are you?
Intermediate.
I think the N just stands for NPH. Yeah. But you guys are coming up with such great things, I was starting to second guess myself. So the N just stands for NPH. And so it is important for you to be able to see those brand names and know which type of insulin it is. So that's something that they might ask you on the NAPLEX, and is something that I think pharmacists should know. But again, we don't use this as often anymore. Most often people are either on insulin glargine or insulin degludec. And we'll talk more about these here in just a second. Glargine comes in with lots of different brand names. So Basaglar is an insulin glargine. You've got Symgli, you've got Resvoglar. And I'm seeing patients on all of these now. Let's see here. There is a more concentrated form of glargine. It's brand name 2JO. And so if you ever see 2JO, that's the U300. So it's 3 times the concentration of just regular U100 glargine. So how do you think you pick which of these that you would use for a patient? How long you want it to last? Yep, that'd definitely be one thing. And that's why we prefer the glargine through degludec versus the NPH. What else? Something we just talked about. Diet and lifestyle could plays a role in why NPH is difficult. Yeah. But what if we're just trying to think between like glargine and degludec? Don't overthink it. It's something we just talked about. something very practical.
Formulary?
Formulary, yeah. So a lot of times we'll pick this based off of their formulary. So Lantus, Bacillar, simply, you would want to see which of these is on their formulary and prescribe whichever one is. So that's really the main thing that I use, is I try to determine what their formulary is and prescribe that. A lot of these are not interchangeable. So if you prescribe Lantus, you can only fill either Lantus or Simply. Simply is interchangeable. But if you prescribe Bacillar, but their formulary is Lantus, then you have to get a new prescription from the provider. So it's unfortunately difficult for providers to figure out what's on formulary, and there's a lot of back and forth that goes on between the pharmacist and the provider. So we're going to start with NPH and then work our way up in our last couple of minutes. So NPH, like I said, is not used a whole lot anymore, and most of that is due to its kinetics effects here. So where do you see as kind of the peak here? How many hours is that? 5.
5.5.
So let's say this person sits down and eats breakfast, takes their NPH insulin. When is it going to take peak effect if they did this at like 8 o'clock in the morning? Yeah, around 1. So kind of around lunchtime. So kind of to George's point about like knowing their lifestyle routine and their diet routine. What do you think would happen if a patient skipped lunch and is on this insulin? Yeah, they'll have hypoglycemia. So it's a really tricky insulin to dose because it is a long-acting one, so you take it kind of without regards to meals, but it has a peak there around lunchtime if you take it in the morning. So if people don't eat regular meals and don't regularly eat lunch, we would see a lot of hypoglycemia. Plus, it doesn't last the full 24 hours. So to compensate for that, generally it's dosed twice a day, and you would take another dose with dinner, a smaller dose. But then if you take a dose at dinner, when is it gonna peak? At nighttime when you're sleeping. So sometimes patients would be like, oh, I felt like I had to have a snack before I went to bed, and it was because they were on this type of insulin where it would peak at night. A lot of times now, I do not recommend snacks before bed because most people are not on this type of insulin, but that was a lot of times the mentality when people were on this, is they kind of had to out-eat their insulin because they would have to use loads hours after. So often it was dosed with about 2/3 of the daily dose in the morning and then 1/3 in the evening. It is available without a prescription. So I don't know if you guys, how many of you are at community pharmacies, and has anyone sold this to someone that just picked it up over the counter without a prescription? A lot of times people will get it at Walmart. Does anyone work at Walmart pharmacy? So they're still behind the counter, so you would have to go to the pharmacy, but they don't require, this particular type of insulin doesn't require a prescription. These are the pictures of the vials at Walmart. These also cause quite a bit of insulin stacking. So if you were to envision that second dose that you would take about right here, insulin stacking is what it's called when you still have some of the insulin from the last dose on board. So if you take another dose of this here, you have that insulin plus the insulin that they were on before. So that was another issue with this. That would increase hypoglycemia risk. So again, we don't typically use this anymore. Switching to glargine. Let's see here. Oh, we don't have time for glargine, so we will start glargine tomorrow. What I would do as homework is review the different classes of insulin a little bit beforehand, and even take a peek at some of the calculations that we have, because I think this can be like a little confusing for people. It's not difficult stuff, but the more you see it, And the more you think about it ahead of time, I think will really set you up for success tomorrow.
If you have 10 minutes, if you can complete that survey for Professor Moore, we need 5 more P3 students. So if you haven't done it, you can do it, that would be phenomenal. We would appreciate that, okay?
Alright. Okay,
Okay.
sounds good, thank you.
Oh,